All right. Hello. My name is Chris Fox. I appreciate being here. I'm a nurse practitioner and an HIV specialist, and currently I work in the HIV clinic at OHSU. I'm also a nurse practitioner at qcareplus.com, which is a online startup that does PrEP through telemedicine. Prior to becoming a nurse practitioner, I also work for the San Francisco Department of Public Health doing contact tracing and partner services for syphilis and HIV. I also work for the San Francisco AIDS Foundation as a nurse in their sexual health clinic. So for many years, I've been involved in HIV and STIs, and I'm excited to talk about some updates to HIV prevention and STIs with you today. So I have no disclosures. So here's the learning objectives for today's talk. So first, we're going to talk about some epi trends in STIs and HIV. Then we're going to go through post or pre-exposure prophylaxis for HIV or PrEP. We're going to talk about what exactly it is, identify people that would benefit from it, and kind of go through the process of starting and monitoring PrEP. Then I'm going to talk more about how to transition someone from a non-occupational post-exposure prophylaxis to PrEP. And then I'm going to go through some changes to the 2021 STI guidelines that were just released last month. So like I just said, so we do have some new guidelines. The STI guidelines are hot off the press. So I'm going to be going through some of those changes. We are also anticipating that we'll have new PrEP guidelines at some point this year. The last time these guidelines were reviewed or edited were in, I believe it was in 2017. So they're due for an update. And what I'm going to do is go through, I'm going to teach both the old and the new guidelines. And highlight some areas where there's differences that I'm anticipating, but we won't know for sure what's in the guidelines until they're actually published. All right, epidemiology. So HIV in the United States, we still have about 1.2 million people living with HIV in the US. I think it's super important to point out that 12% are unaware of their status, so they're walking around with HIV and have no idea. In 2019, which is the last year that we have surveillance data from the Centers for Disease Control, there were about 35,000 new HIV diagnoses. And there's always, with the CDC, there's always about a 1 to 2 year lag in reporting of surveillance data. So 2019 is what we have to look at right now. There is a decreasing trend overall in new HIV diagnoses, but not in all groups. And the couple groups that I wanted to highlight are young adults and Black Americans. So this slide from the CDC shows some HIV disparities related to age. So if you look at the different age groups here, the different colored lines, the sort of yellowish orange line is the 25 to 34-year-old group. And you can see over the last decade, the new HIV diagnosis numbers have been trending up in that group, although in 2019 they dipped a little bit. My expectation is probably it's going to continue to go up, but we'll have to see what the data shows. And then you'll see all these other groups, they're trending down for the most part, except for maybe the 35 to 44-year-olds who are kind of flatlining there. This slide, also from the CDC, shows some key racial disparities in HIV incidence. So if you look at the longest bars here, for white Americans, the teal or sort of bluish color is the actual population of that race in the United States. So about 62% of all people in the United States are white. But they have about 25% of the new HIV diagnoses. Whereas if you compare that to, if you move up a little bit to Black Americans, although Black Americans only make up 12% of the US population, 41% of new HIV diagnoses are in this race. And if you look at Latinx populations, although they make up 17% of the population in the US, there is an incidence of about 29% of all new HIV cases. So I think there's some significant racial disparities here. I always, whenever I'm talking about race and health issues, I always want to highlight that there's nothing inherently biological about a certain race having increased numbers. This is really all about structural racism, things like access to healthcare, trust of the health system, and so on. So I just want to highlight those disparities there. This map shows HIV incidence in 2019 across the United States. You can see Oregon is sort of like a low to mid, has sort of like that pink, the sort of light pink color. It sort of has low to mid HIV incidence compared to some other states. But the hotspots for HIV in the United States are still primarily in the Southeast, and then California, Texas, and New York State. So switching to STDs, so in 2019, we had our 6th consecutive year of record-breaking STD cases. So they went over the past 5 to 6 years, they went from about 1.9 million up to 2.6 million. And I think that this trend, we're all kind of expecting that this trend is going to continue based on what's happened in the last year to 2 years with the COVID pandemic. Looking at specific STDs, so chlamydia, still the highest reported sexually transmitted infection in the United States in 2019. There were almost 2 million cases, which was an increase of about 2.8% compared to 2018. You can see on the graph here that women tend to have more cases than men when it comes to chlamydia. Looking at gonorrhea, there were just a little over 600,000 cases in 2019. But what's important is that there was a 92% increase from a historic low about a decade earlier in 2009. And you can see here that men tend to have more of the gonorrhea cases than women, and a lot of that is related to spread of gonorrhea among men who have sex with men. Syphilis has totally skyrocketed over the last few years. So this slide shows the total syphilis cases. In 2019, were about 130,000 cases, including nearly 40,000 primary or secondary cases where people are the most infectious and most likely to spread syphilis to other folks. It's key to note that there between 2018 and 2019, there was an 11% increase in syphilis rates. And since the historic low that we saw in 2000, when we actually thought we were going to eradicate syphilis from the planet, we've been seeing increasing rates every year. And this isn't significant because what we're really, I think sort of the real tragedy of syphilis, other than an adult being infected with it and having some kind of complication, is the possibility of congenital syphilis. When I was working for the health department in San Francisco, it was at a time when we rarely had a congenital syphilis case, and any case was really treated as sort of an emergency. And we were looking at, we would be looking to see what we did wrong that allowed this case to happen, because it's a completely sort of preventable situation. But since since 2005 or 2015, we've had increasing rates of congenital syphilis across the country, including in Oregon. This slide actually sort of mirrors the national numbers that I just showed you. You can see that in 2013, there were no cases of congenital syphilis in Oregon. And then the number has steadily increased over the last few years. In 2020, there were 19 cases. And this is a real tragedy. To have an infant or baby born with a syphilis infection is completely preventable, and just a very tragic situation. So now we're going to look a little bit at the COVID impact of the COVID-19 pandemic on HIV and STIs. In the beginning of the pandemic, we had a lot of what epidemiologists are calling sexual distancing. So people were not having as much sex or not having as much sex with as many different people as prior to the pandemic. We also saw reductions in clinical services. So clinics would reduce their hours or not allow patients to come in and be seen in person. There was a lot of telemedicine going on, a lot less screening, a lot less testing. We don't know exactly whether the COVID pandemic is going to increase or decrease STI and HIV rates. But there is some modeling from a group of epidemiologists on the East Coast that suggests that if we end sexual distancing without also increasing key services like testing and treatment, we may have significantly higher STI rates. And part of that, I think, is, we can kind of see that happening right now as people are getting vaccinated. Especially in my work at qcareplus.com, I talk to people that are getting on PrEP because they are, they've been vaccinated. The pandemic is sort of loosening up a little bit and they're ready to go out and have sex again. But unfortunately, we're also seeing that a lot of key clinical services are not yet opening up at sort of the same rate. And just anecdotally, many clinicians that I've talked to or know about are just kind of bracing themselves for an STI and HIV boom. I know in my practice, I've seen a lot more people with new HIV diagnoses over the last few months than I typically do. So we'll have to see what this looks like, when all of the surveillance data is collected. But I think that we're probably heading towards further increases in STIs and HIVs over the next years. So this slide shows some data from Oregon. So this is data on testing for HIV and STIs in the at the Oregon State Public Health Lab. So this graph right here shows HIV tests. So the blue line is 2019 when there wasn't a COVID pandemic, and then the red line is 2020. And what you can see is that there was a real dip in the number of tests that were being run by the lab over March and April of last year, almost to no tests at all. And then there's been a sort of a slow rebound, but it has not rebounded to the numbers of tests that were done previous to the pandemic. So I think this kind of points out some of the, what I was talking about in terms of people having more sex, but clinical services not yet sort of amping back up as well. This slide shows syphilis. Syphilis also dipped around March and April and has slowly been rebounding, but is nowhere near the number of tests that were done in 2019. And then this shows the gonorrhea, chlamydia, NAT tests. You can see that they also dipped at the beginning of the pandemic, and they've rebounded a little bit, but not very much. This slide is going to look at, so compared to testing, this is going to look at new diagnoses. So sort of same color scheme, blue is 2019, red is 2020. And you can see that there were, for HIV, there were decreased numbers at the beginning of the pandemic. And then they've kind of rebounded since in the latter half of 2020. I'm not sure where they're at right now, but like I said, just anecdotally, it feels like the numbers have gone up in my practice. When you look at something like early syphilis, so primary and secondary syphilis, there was a dip around the same time last year in number of cases. And syphilis has actually rebounded significantly since over the latter half of 2020. You can see here, there's almost a, like maybe a 30 or 40% increase by the end of the year. So this is a very concerning trend. And this is, if you compare this to the last slide where there were actually fewer tests occurring, this is particularly alarming. Here's gonorrhea, so it shows the same dip in diagnoses, and then it has sort of rebounded despite fewer tests being done. And then here's chlamydia, which has almost rebounded up to where it was previously. So that's enough epi, I think. So now we're going to talk about PrEP. So we'll just kind of go through the process of what is PrEP, how would you identify someone who may benefit from it, and how would you manage that person. So prophylaxis means prevention. So HIV is a HIV prevention strategy where people with substantial risk for HIV take a medication daily, along with other risk reduction strategies like condoms or decreasing the number of sex partners, et cetera. And this is something, the idea of using a medication as prevention against an infectious disease is something that's well established. And if you think about if you've ever traveled to an area of the world that is endemic for malaria, you may have taken chloroquine to prevent infection there. So this is sort of a strategy that is well established. Currently, there are two PrEP options. So one is Truvada. That's the last time I'll mention the brand name. I'm going to call it FTDF based on the components of it. So it includes tenofovir disoproxil fumarate and emtricitabine. It was the first agent approved for PrEP, or the first regimen approved for PrEP in 2012. And there's now actually a generic version available. The other option is Descovy, which is the brand name, which I'm going to call FTAF. And it is comprised of tenofovir, alafenamide, and emtricitabine. And it was approved about 2 years ago by the FDA. These two regimens have the same active ingredients, but they're formulated a little differently, so that one obviously has a smaller pill size, and there's some other toxicity differences between them, which we'll talk about. But these are the two options that we have right now. We're expecting by the end of the year, we're going to have our first injectable medication for PrEP, which is cabotegravir. This is the 2021 PrEP guidelines. Even though this medication has not yet been approved by the FDA, are anticipated to include information about managing someone who's on cabotegravir for PrEP. It would be a once every other month dose. We're expecting that it's going to be approved for both men and women, and there's not a whole lot in the way of monitoring for toxicities with it. It is, however, a medication that has to be administered very precisely in the ventrogluteal site, and it's probably not going to be something that people are going to be able to inject at home. It's something that will have to be given in the clinic. It's also very expensive. So it's, you know, we'll have to see what it's like when this medication rolls out for PrEP, but it's coming down the pipe. I wanted to show some data around the efficacy of PrEP. So these are some key early studies for PrEP. So Partners PrEP, TDF2, IPREX was very famous study among men who have sex with men. And then two studies, FemPrEP and Voice, that were involved female participants only. And you can see there's some varying efficacy, 75% all the way down to 0%. And these numbers don't look super great, but if you factor in adherence, the numbers really change. So if you look at the bars here, the dark bars are the efficacy of all participants in these studies, whereas the light bars sort of extend out for those participants who were most adherent. So you can see that when people adhere to PrEP, the numbers go up to the 90% efficacy. The two studies with women at the bottom, they were both sort of failures in terms of PrEP efficacy, but also when they went back and tested drug levels, they found that the participants really weren't taking the medication. So if you have a bottle of PrEP and it's on a shelf in your bathroom or in your backpack or whatever, it's not going to protect you from HIV there. You actually have to take it. PrEP is likely making a difference in terms of the overall new HIV diagnoses in the United States. So this graph shows So what basically what they've done is they've split the United States population or states into 5 groups based on how much PrEP is being prescribed in those groups. And they took the portion of the states with the highest number of PrEP prescriptions. And as PrEP use has increased, which is the sort of purplish or maroonish bars over the last decade, as PrEP use has increased, you can see that the number of new HIV diagnoses have gone down. So those are the gray bars. So there seems to be an impact for those areas where PrEP has really been utilized. There seems to be an impact on new HIV diagnoses. National guidelines are currently recommending PrEP. Like I said, so the CDC last published PrEP guidelines in 2017. They said that PrEP is effective, safe, and recommended as an HIV prevention option for men who have sex with men, heterosexual men and women who have risk for HIV, and people who are injecting drugs. And they also mentioned that PrEP should be discussed in settings where someone might be trying to conceive a child or be pregnant when one of the partners has HIV infection. The United States Preventative Services Task Force also recommends PrEP. They've given it an A grade, which is sort of the standard with the task force. And they recommend that clinicians offer PrEP to anyone who has high risk of HIV acquisition. There's also some huge psychological benefits from PrEP, and I think this slide can't be sort of emphasized enough. The way that PrEP changes the dynamics of sexual relationships and how people feel about themselves and their risk for HIV is incredible. It replaces fear with more of a focus on relationships. Danger goes away and people can focus more on personal connections. There's a movement from self-doubt to self-efficacy. People don't have to worry about HIV transmission anymore. There's a peace of mind. There's a shift from feeling like you're at risk to minimizing the risk to other people, moving from powerless to empowerment and hopelessness to hope. I think it's important that there's a lot of people, especially men who have sex with men, who potentially prior to PrEP never had any sort of sexual encounter where they weren't afraid, at least somewhat, of acquiring HIV infection. And this has really changed that. There's huge psychological benefits to PrEP. All right, so let's talk more specifically about who PrEP might be indicated for. So I'm going to present a case study here. This case study actually came from a colleague of mine, Devin Flynn, who's a pharmacist who reviews a lot of the NPEP cases that occur in the OHSU emergency department. She's reviewing all of these cases, and I asked her to provide me some involving some sexual assaults that might illustrate how PrEP might be utilized. So YL is a 21-year-old cisgendered woman. She presents to the emergency department today for an quote, alleged sexual assault. She has 2 other visits for sexual assault in the past 16 months. NPEP was offered at 1 visit, but not the other. And the chart notes remark that the patient has a mood disorder or intellectual disability. So she has been offered NPEP, and that will be started today. So the question is, would you offer her PrEP as well? And for a patient like this, I think there's some things that stand out to me. So one of them is that there's, I put quotes around some things, some words that were documented in the chart that sort of question the validity of the patient's report of having been sexually assaulted, which makes me worried that there's at least some disbelief and that she's not going to, even if she's at HIV risk from these sexual assaults, that she may not be offered NPEP every time that occurs. So she might benefit from having PrEP on board. The same thing with the mood disorder and intellectual disability. There's sort of, I get worried that this patient is not going to get the services they need when they go into the emergency department, when there's this sort of doubt cast around them. And she's had multiple sexual assaults, so she's definitely at risk for HIV. So looking at the guidelines, who is a good candidate PrEP. So it would be anyone who has a substantial risk for acquiring HIV. And they've broken down some factors that might indicate that someone has substantial risk. So for both men who have sex with men and heterosexual women and men, anyone who has a HIV positive sex partner, anyone who's had a recent STD, people who have multiple sex partners, anyone who inconsistently uses barriers like condoms, anyone involved in sex work. And then for heterosexual men and women, also thinking about what is the prevalence in the area that the folks are living in, or their individual sexual networks. And then for people who inject drugs, it's really anyone who has an HIV positive injecting partner or anyone who's sharing equipment. In the 2021 PrEP guidelines, we're expecting there to be sort of a simplification of all of this. The guidelines are going to recommend that all sexually active adults and adolescents should be informed about PrEP for prevention of HIV acquisition. And the idea behind this is one, by spreading the news about PrEP, people may go back to their family and social networks and talk about PrEP with other people. So even if someone doesn't have substantial HIV risk themselves, they might know someone who does, and they may not know about PrEP. We have to remember that patients are not always going to disclose all of their risk behaviors because of stigma. So, you know, just because someone hasn't told you that that they have multiple sex partners or that they have an HIV positive sex partner does not mean that you know that they actually don't. And then the guidelines are also going to emphasize that really anyone who asks for PrEP, even if they don't state any obvious risk factors, should be offered PrEP. And this is something that I find in my practice. Sometimes people will not necessarily disclose their entire risk to me, and they're asking for PrEP, and I'm thinking like, I don't know if you need this, but I always provide it to them. There are some people that PrEP is not appropriate for. So anyone who does not have a verified, that we don't know for sure that they're HIV negative, should not be put on PrEP. And this should be obvious as well. So anyone who's already HIV positive should not be put on PrEP. The medications that are in PrEP are actually medications that we use to treat HIV infection, but they are a partial, if they were to just be used, if you were just to take, you know, TDF or F-TAF for HIV treatment, that would be a partial regimen, and you would likely develop a viral resistance, which would make HIV very difficult to treat in the future. So they can't be relied upon as a full treatment for HIV. Anyone who's had a possible exposure in the last 72 hours to PrEP should not be offered PrEP. They should be offered NPEP. And then down the road, PrEP can be considered. We'll talk a little bit more about that later on. Anyone who has significant kidney disease, so FTDF is contraindicated if someone has creatinine clearance below 60, and F-TAF is contraindicated for anyone with a creatinine clearance below 30. There are also individuals for whom PrEP, there should be caution when given PrEP. So these are people that don't necessarily have an absolute contraindication to PrEP, but if they are on PrEP, they need to be watched a little bit more closely. So one is people that have chronic hepatitis B infection. The medications in FTDF and F-TAF are actually used for treatment of chronic hepatitis B. And if you were to start someone on PrEP and then stop it, they could have a flare of their hepatitis B infection and potentially have fulminant liver failure. So it's an important thing to know about. Anyone who has a flu-like illness where you're thinking maybe it could be an acute HIV infection, they can be offered PrEP, but we really need to check their HIV viral load before starting PrEP to make sure that they're not actually HIV positive. Anyone that doesn't necessarily have kidney disease but has risk factors like diabetes or hypertension, these are folks who can be offered PrEP, but we need to monitor their kidney function more frequently. Anyone who has difficulty with adherence, so I'm thinking about, if someone is constantly losing their medications, constantly forgetting to take their medications, only taking PrEP here and there, that is someone that I would be cautious about and just make sure that I'm really doing my best to do adherence counseling. There are some bone toxicity issues with these regimens. So anyone who already has osteoporosis, you'd have to have a sort of a shared decision-making conversation with the patient about risks and benefits and whether the need for HIV prevention outweighs the sort of potential risks to bone density. And then PrEP is approved for adolescents that are over 35 kilograms. But we know that adolescents are generally very bad at taking medications of all kinds. So you just want to provide more support around adherence for anyone who's younger that you'd be offering PrEP. I wanted to mention a little bit about PrEP and U equals U, or undetected equals untransmittable. So if someone has an HIV, so if someone does not have HIV, but they have a sex partner who is living with HIV and has stable viral suppression, so they have an undetectable viral load, does the HIV negative partner really need PrEP? If you're not aware what U equals U means originally, so it's also known as treatment as prevention. We now know it's a scientifically established fact that if someone has a viral load below 200 copies and they are stable, so they're taking their treatment, taking their medications, there is zero risk of HIV transmission. This really comes out of 4 key observational studies of both heterosexual and homosexual sex encounters where almost 150 sex acts occurred, and there were absolutely no linked transmissions of HIV infection. We don't know really if U equals U applies to other potential exposures, like through breast milk or in injecting drug use. But I think that if you were to have a patient like this who's HIV negative and they have an HIV positive partner who has an undetectable viral load, there really should be some shared decision making around PrEP, whether PrEP is necessary. It really kind of depends on the relationship they have, how comfortable the person without HIV feels, sort of putting the HIV risk reduction strategy in the hands of someone else. PrEP could be a way that they sort of have some control over their own HIV prevention, but just like clearly scientifically sort of thinking, if U equals U is involved, they've already have very strong very strong risk reduction strategy in place. So PrEP may not be appropriate for that person as well. Okay, let's talk a little bit about the nuts and bolts of PrEP initiation and monitoring. So I put a cookbook on this slide because I think that getting someone on PrEP is really sort of a cookbook type process. It's kind of a recipe type process. First thing we do is we want to confirm their HIV status and review additional labs to make sure that PrEP is appropriate for them. We're going to provide a lot of counseling. We'll select a regimen and then prescribe PrEP. And then there's routine monitoring that occurs. So screening for HIV, at minimum, you want to make sure that you document a negative HIV screening within 7 days before starting PrEP. Ideally, this should be a blood-based screening. The oral rapid tests are not as accurate. So ideally, it should be either a serum draw or a finger stick. If you have a negative or indeterminate screening in someone who has recent HIV exposure or has some symptoms that could be a new HIV infection, that kind of flu-like illness, you would want to make sure that you either repeat the test in about a month and possibly defer the PrEP decision during that time. Or if you have access to it, you could also send an RNA PCR, which is a viral load, and see if they have evidence of an HIV infection. There are some additional labs to order. So creatinine, so that you can calculate how well their kidneys are filtering. Screening for STDs, so gonorrhea, chlamydia, syphilis. Checking to make sure that they don't have an active chronic hepatitis B infection related to what I discussed before about how you could cause them to have sort of a fulminant liver failure if you were to abruptly take them off PrEP and they have chronic hepatitis B. Want to go ahead and screen them for hepatitis C just based on risk. And then anyone who has a uterus and is of childbearing age needs to have a pregnancy test. And that goes for transgender individuals who are on hormones. Also, as appropriate, you want to make sure that you provide some vaccinations, so hepatitis A, B, and then the HPV vaccinations as indicated. So there are a lot of counseling. There's a lot of counseling that occurs with a PrEP start. You want to explain to the patient how PrEP works. Always say, you know, taken daily, and if you have excellent adherence, it's not just the pill bottles, not just sitting on the, you know, a shelf in your bathroom. You're actually taking it. It's over 90% effective at preventing HIV, and it might be as high as 99% with some studies. For anyone who is on FTDF, the maximum drug levels in rectal tissues are achieved at about 7 days, and in blood and vaginal tissues after about 21 days. So I always tell people, like, don't think that you have this over 90% risk reduction on board until you have been on the medication for a while. With FTAF, the maximum drug levels in the rectal tissues are also occur after 7 days. But it's important to know that FTAF is not approved for people who are going to be having vaginal sex or people who are injecting drugs. So I think that's just a really important point to make. And then if someone is planning to stop PrEP, ideally they should continue PrEP for 28 days after their last potential HIV exposure, and then get HIV tested again. And this might be kind of obvious to us, but a lot of patients have the question, like, will PrEP protect me from other STIs? And the answer is no. So it's only for HIV protection. If you want to protect yourself from syphilis, gonorrhea, chlamydia, using a barrier is still your best bet. Some other counseling topics. So again, stressing the importance of daily adherence, trying to get the patient to link their dosing to something that they do every day anyways. So making sure that they take their dose when they brush their teeth or when they have their morning cup of coffee, whatever it is that they do every day in their routine. Provide some education and counseling on condom use and other risk reduction strategies. Review safer drug injection practices. Talk about the need for regular follow-up visits and lab tests, which are quarterly. Really emphasize to the patient that regular lab monitoring is required for someone who is on PrEP. Always want to do a review of someone's reproductive goals and whether they're using contraception. Talk to patients about what to expect if they were to have a new HIV infection, if they were to have, you know, high fevers, drenching night sweats, severe rash, severe sore throat, nausea, vomiting, just feel really terrible. They need to reach out and get evaluated for an acute HIV infection. Talk to patients about, you know, if they're kind of abruptly stopping and restarting PrEP, they really need to talk to their provider before they restart, just to make sure that, you know, that it's still appropriate for them to be on PrEP, and that, you know, that all of the necessary lab work has been done and is up to date. Counsel on different insurance and medication assistance programs. So PrEP is very expensive. It's part of the Affordable Care Act now that PrEP should be covered by all insurances, but you still might find that there's people are confronted with a copay that can be quite high. So the manufacturers of these medications do have a copay assistance program for patients. You want to review refill policies and procedures, and then also go over side effects and adverse effects. So as far as side effects, there's really not that much. About 10% of patients have what we call an initiation syndrome, where they may have nausea and a headache, last for about 2 to 4 weeks. Sometimes they might have mild diarrhea as well. For most people, these are pretty mild symptoms, and they're just able to sort of tough it out. Occasionally, someone might have more severe symptoms, so they need some additional support getting through this initiation period. But after that, most people don't really have any side effects with these medications. I mean, with any medication, there might be a rare individual that just really doesn't tolerate it because of GI side effects or something like that, but that's pretty rare. In terms of adverse effects, so with both TDF and FTAF, there is a small risk of kidney problems and bone mineral problems. Usually, the kidney problems we can identify quickly because we're monitoring kidney function while someone is on PrEP, and the disease, the kidney injury, is reversed if we stop PrEP. These kidney problems could include Fanconi syndrome. So it's rare that this happens, but it's something that we're definitely monitoring for. And then bone density it's kind of tricky. So being on PrEP does decrease bone density, but there's no real evidence that it actually increases the risk of fractures or moves people towards osteopenia or osteoporosis, where they're having sort of pathologically low bone density. But it is something that I always talk to patients about as a potential adverse effect. So what about PrEP and pregnancy? So both PrEP and U=U are great strategies for people that are trying to conceive. If one person is HIV negative and the other one is HIV positive, they're serodifferent. We know that there is a risk of acquiring HIV during pregnancy due to many factors. A lot of times women have less ability to negotiate condom use. In some societies, the male partner may be more likely during the pregnancy period to go out and have outside sex partners. Pregnancy also changes power dynamics that can increase things like intimate partner violence and things like that. So women or anyone who is pregnant is going to be at increased risk for HIV. What we know is that PrEP does not seem to have any influence on birth outcomes, so it doesn't seem to hurt the baby. However, TDF levels, so tenofovir levels, can decrease by about half during pregnancy, even with excellent adherence. So counseling a patient about the importance of adherence is very key for someone who's pregnant. And I just wanted to point out this website, Hive Online. It's a organization in San Francisco that provides all kinds of family planning and HIV information, both for clinicians, for consumers and patients. It's a great website. They have all kinds of algorithms that you can work through if you're trying to make a decision about some kind of HIV risk reduction strategy with a patient. They have patient testimonials. It's really a great website, and I recommend that you check it out. So once you've done the workup and counseling, then you write a prescription, or someone else will write a prescription for PrEP. And the key thing with this is that you never want to prescribe more than 90 days at a time. So I've seen instances where someone has been given a prescription for FTDF for 1 year, and that's completely inappropriate. We need to be monitoring kidney function and HIV status while someone is on PrEP. Which brings me to follow up. So for some patients, you might do some testing within about a month of starting PrEP. So if you're really concerned about someone's HIV status and you want to test them again, some people might need some more support around adherence and side effects. But at least every 3 months, you want to make sure the patient gets tested for HIV, that there is a pregnancy test if indicated. You always want to talk about adherence, make sure they're taking their medications, try to troubleshoot ways for increasing adherence if they're having problems. Talk about other risk reduction strategies. Ask them whether they've had any flu-like symptoms that could be a new HIV infection. Make sure that they need to continue on PrEP. So actually ask them, are you using this? Do you need this? And then provide another 3-month or 90-day refill. We also get some renal function testing, at baseline, and then every 3 months, or at the first 3 months that someone is on PrEP, we get creatinine, and then you can do renal function testing every 6 months thereafter, unless someone has diabetes or hypertension or some other sort of risk factor for kidney disease. You might want to check them every 3 months. And then at least every 6 months, you want to be testing for STIs. In my opinion, I always order it every 3 months. I figure if you're at risk for HIV, you're at risk for these other infections as well. So we should be doing our due diligence to make sure that people get screened. Lab monitoring may be changing with the upcoming guidelines that are going to be released this year. So for people that are younger than 50 and have a high creatinine clearance at baseline, creatinine clearance monitoring may change to just once a year. Everyone else would continue to get at least 6 months. So if someone is older than age 50 or they have a lower creatinine clearance. And then for folks that have increased risk for HIV, of course, we're going to just continue to monitor them. Increased risk for kidney disease. We're going to continue to monitor them to make sure that PrEP isn't causing any problems. We might want to add a urinalysis to assess for proteinuria in specific patients as well. And then continue the screenings for HIV every 3 months, and then STIs in pregnancy. So if you might be asking, like, what if someone doesn't have frequent HIV risk? So there is an alternative dosing strategy called 2-1-1 dosing. Sometimes it's called on-demand dosing or event-based dosing. This would be a strategy where a person only takes PrEP around a period of increased risk for HIV. It is important to note that this is not FDA approved, so it is off-label, but there is data to support it, and the new guidelines that are coming out are expected to talk about 2-1-1 dosing. The way it works basically is that someone will say, hey, I'm going to be having sex or having risk for HIV in the next 24 hours. So 2 to 24 hours before that encounter, they're going to take 2 tablets of FTDF. And then 24 hours later, they will take 1 tablet. And then they will have 24 hours where they're not having HIV risk. They'll take a final tablet of FTDF. And then that's the cycle. If someone has repeated exposures to HIV, so they continue to have sex over a period of time, they just keep taking a tablet every day until they've gone 24 hours without an potential HIV exposure, take a final dose, and then that's it for the cycle. So so for 2-1-1 dosing, there is evidence. There's a study out of Europe called the IPRGAY study, which has shown that there's potentially 97% risk reduction with 2-1-1 dosing. But it's important to know that it's only for anal sex. It has only been studied for HIV risk related to anal sex. So anyone who has vaginal sex or front hole sex, 2-1-1 is not appropriate for them, unfortunately. It's only been studied in FTDF, so we don't know if it works for FTAF. So there's only one option in terms of regimen. I think this is so important. So adherence is key. You really have to have someone that is organized and can anticipate or predict that they're going to be having sex in the next 24 hours, and then follow the dosing schedule afterwards. For a lot of people, it's hard. It's easier to take a medication every day sometimes than it is to sort of take it on an irregular basis. So someone must really be organized. If someone has chronic hepatitis B, obviously you can't be taking them on and off hepatitis B treatment. It may be less effective with hormone use. So if someone is on hormones for gender affirming care, I wouldn't say that 2-1-1 is completely inappropriate, but I think that the adherence portion is super key. And then if someone is taking more than 15 doses a month, or if they're having sex more than once a week, probably being on daily PrEP is a better option for them. All right, I'm just gonna briefly compare the two regimens. And this is really the heart of the difference between them. So they're the same active ingredients. Both of them break down to this diphosphate metabolite of tenofovir that actually targets HIV. But they kind of break down in different ways. So FTDF is formulated to where there's a pretty high dose. It's about 300 milligrams per dose. And a lot of that dose actually ends up in the plasma circulation. And that's where it can cause things like bones and kidneys to be exposed to tenofovir. Whereas TAF, it's a much smaller dose, and almost all of the TAF actually ends up in the target cells for HIV. Very little of it ends up in the plasma circulation. So there's just slightly less toxicity with TAF compared to TDF. I think that the way that I describe this to patients, because patients don't really know about, pharmacokinetics and dynamics, I usually say, FTDF is sort of like, it's sort of like you're trying to shoot a target, and FTDF is sort of like a machine gun. So it's just spraying all over the place. So there's a lot of collateral damage. Whereas TAF, it's more like a bow and arrow. So you're going to have, this more targeted, and there's less damage around the target. So does one work better than the other? There was actually a trial looking at that question. Over 5,000 patients were randomized to either FTDF or TAF. There were some HIV infections during the study, but they were all attributed to either someone coming into the study with HIV already, or they did not have adherence during the study. And then there were a few that discontinued due to kidney side effects. But in the end, the study concluded that after 96 weeks, FTAF is not inferior to FTDF for HIV prevention. So both of them work just as well. Is one of them safer? So kind of touched on this. Tenofovir, as I've said, has well-known bone and kidney toxicities, primarily in the setting of HIV treatment, where someone is on these medications potentially for the rest of their life. And HIV itself causes bone and kidney issues, or can cause bone and kidney issues. So these are things that are well known. It seems like this toxicity issue is less of an issue with PrEP, however. And there's not a huge amount of difference between bone and renal toxicity between FTAF and FTDF, despite the way that they're formulated differently. So the way that I think about this is that pretty much everyone is going to be okay with FTDF. But FTAF might be appropriate for some patients, so people that are the appropriate patients, so either men who have sex with men or transgender women who have some additional risk factors for kidney or bone disease. This is a slide from Julia Marcus, who's an epidemiologist at Harvard, which I just love. She really breaks down the differences between FTDF and FTAF in terms of all of the toxicity issues and the effectiveness as well. So this is something to print out and put on your wall if you're doing a lot of PrEP prescribing. So how would you transition someone from non-occupational post-exposure prophylaxis to pre-exposure prophylaxis? And I'm going to assume here that you already know how to initiate someone on NPEP. So we're going to talk more about the transition to PrEP. I have another case study here to think about. So GT is 33 years old. He's a transgender man. He presents to the emergency department following a sexual assault. He's had multiple emergency room visits for skin infections and has a history of injecting meth. He's houseless. He's often injects with people who can provide him with temporary shelter or a couch to sleep on, things like that. And he is well connected to some local social service agencies. So for GT, NPEP is started today, and he is also interested in PrEP. So how would you make that transition? So just hopefully this is something you know, but just to review, so NPEP is non-occupational post-exposure prophylaxis. It is antiretroviral medications that you take after an HIV exposure to prevent infections. The evidence is primarily based on expert opinion, although there was a case-controlled study back in the 90s that showed about 81% risk reduction for HIV infection with AZT for occupational occupational HIV exposure. So someone having like a needle stick. And there are two main regimens right now that are composed of 3 antiretroviral agents that are used for 28 days. So there's a dolutegravir plus FTDF, and there's a raltegravir plus FTDF. So there are 2 ways to make this transition from NPEP to PrEP, and the first would be the immediate transition. And this is preferred, especially if someone has ongoing risk for HIV. The drawback is that if someone has a new HIV infection, it might make detection of that infection more difficult. And basically what you do is at the end of 28 days on NPEP, you have the patient do a rapid HIV test, and you ask them about whether they've had any acute HIV infection symptoms. And then based on the test results, you have one of the following steps. So if someone has a preliminary HIV positive result, or there's high clinical suspicion that they might have HIV, you would just continue the 3-drug regimen of NPEP, and then draw confirmatory HIV testing. You know, if they have a confirmed positive HIV test, of course, they need to be referred to HIV care, and you want to continue them on the NPEP regimen. That's super important. People are going to do much better clinically if you continue their antiretroviral therapy uninterrupted. So you don't want to stop it just because they completed PEP. And then if someone is negative for HIV, what you would basically do is stop the 3rd agent in the NPEP regimen and continue the 2-drug PrEP regimen, and then do any sort of lab work that needs to be completed for PrEP that's not already been completed. So this is what this looks like kind of graphically. So someone has an HIV exposure on the left. Within 72 hours, they're started on dolutegravir and FTDF. They're on that for 28 days. And then at the end of that, they have a rapid HIV test that's negative. The other PrEP labs are completed, and the dolutegravir, or that DTG, is just sort of dropped from the picture, and then the patient will continue FTDF ongoing with the normal sort of process for PrEP follow-up. The other way to do PrEP is to sort of start PrEP at a later time. So there's going to be a break in between the NPEP and the PrEP. This might increase the risk of HIV exposure for someone who has ongoing risk, but it might be appropriate for some people who need time to make a decision about whether they want to do PrEP. If someone has underlying medical conditions that they're concerned about that need to be addressed, or if someone needs some time to get on insurance or figure out how they're going to pay for PrEP. And basically the process would be that someone would stop NPEP. They would go through the screening process following NPEP, and then as soon as they're able, they would start PrEP. And they would need to complete any sort of outstanding baseline labs at that time. Regardless of testing, I think the key thing is to think about linkage to a prescriber who can provide PrEP. So sometimes the hardest thing is not necessarily the prescribing of the medication, it's finding someone who can follow the patient over time, especially if you're seeing a patient, say in the emergency department, and they're started on NPEP following a sexual assault. They really are going to need to be linked to an outpatient PrEP provider. That could be a primary care provider, could be someone who just does PrEP through a website or through a community clinic, Planned Parenthood, something like that, but they really need to be linked to someone in these situations. Regardless of timing, you always want to offer counseling on sexual and injection risk reduction practices. You always want to provide adherence support, always, always, always. And then don't assume that insurance coverage for NPEP and PrEP will be the same. There may be a difference there that needs to be investigated and troubleshooted. All right, so let's stop talking about HIV prevention for a moment, and I'm going to start reviewing the 2021 CDC STI guidelines. So this update, I'm going to mostly highlight changes to the guidelines from 2015 when they were last published. I'm not going to cover the guidelines in minute detail, but I'm going to talk about the infections that I think are most relevant to you in your practice and are certainly most relevant to me as well. So what's in a name? So the guidelines have actually changed their name. They in 2015 they were STD guidelines, and now they're STI guidelines. So what's that about? So as we know, sexually transmitted, or STD means sexually transmitted disease. That refers to the disease state. So here we have a penis that unfortunately is sick with gonorrhea, so that is an STD. Versus STI, which is a sexually transmitted infection, that actually refers to the pathogen. So here we have some gonorrhea that's under the microscope. So this is an STI. And I think the importance of this is that many of the STIs that are out there, many of these cases are asymptomatic. So when we talk about STIs, we're really focusing on stopping the spread of these infections that often people don't know that they have, and we only pick up through screening. So although this is kind of a very sort of like small semantic issue, I think it's also an important distinction, and I'm glad they've made this change. The guidelines still emphasize primary prevention of STIs and HIV. So of course, vaccinations, condoms, both male and female condoms or external and internal condoms. There's emphasis on PrEP and PEP, emphasis on managing risk by reducing the numbers of sex partners, and then potentially considering male circumcision. For syphilis, there's no changes in screening, diagnosis, or treatment recommendations. The preferred regimen is still bicillin, but I just want to highlight that there's been an alarming increase in the incidence that we discussed before, and particularly regarding congenital infections. So although there's not any changes to the guidelines in terms of management, we definitely need to have syphilis on our radar all the time. And below are some images, some classic images of syphilis symptoms. On the left is someone who has this nickel and dime sort of patchy rash on their hands that doesn't hurt or itch. The middle photo is of someone who has a primary chancre on their penis. So it looks horrible, but it is painless, and the patient may not know that it's there if it's hidden from their view. And then there's a secondary maculopapular rash on the right side that does not itch and can often be very sort of faint and lacy and almost hidden. And I've had times where I'm drawing someone's blood and I'm like, what's this rash on your arm? And they're like, oh, that's just my underlying skin tone. And then we find out, no, it's syphilis. Gonorrhea actually has had some management changes, all related to the issue of drug resistance and gonorrhea. So it's really very much on the public health, the eyes of public health professionals. What are we going to do about gonorrhea that we're running out of medications to treat it? We only have one reliable class at this point. Testing is, NAT testing is preferred for screening. As I mentioned, cephalosporins are the only antibiotic treatment class with reliable susceptibility. And then you also, with treating gonorrhea, you have to really think about anatomical site. So the pharynx or throat is more likely to have some different pharmacokinetics compared to the rectal or vaginal sites. So now the new guidelines recommend that if you're treating a pharyngeal infection, try to get a test of cure at 7 to 10 days after treatment with a NAT. This slide illustrates, what's the big deal about gonorrhea resistance. And you can see on the far left in the 1930s, we used to use sulfonamides to treat gonorrhea, and then those fell out of favor due to resistance. We started using penicillins in the mid 1940s, and then we've had resistance with those. So in the 1980s, we started using more tetracyclines, and then those fell out of favor. And then we started using fluoroquinolones, and then those fell out of favor. And then over the last, decade to 15 years, we've started focusing on the cephalosporins, first cefixime, and now injectable ceftriaxone. And this year we've actually, or with these guidelines, we've actually increased the dose of ceftriaxone. And we used to treat gonorrhea with both ceftriaxone and azithromycin. I kind of think of this as kind of akin to like the multi-drug treatment with tuberculosis. We're trying to attack the gonorrhea in two directions with two different agents, but there has been some emerging azithromycin resistance, so now that is no longer favored. And that's illustrated in this graph here. So you can look at over the last decade, the number, and so this is some surveillance data on gonorrhea. You can see that they've isolated gonorrhea over time, over the last decades, and there's higher numbers of cases that require increased doses of azithromycin in order to successfully treat the gonorrhea. So azithromycin is no longer recommended as part of gonorrhea treatment for first line. So these are the regimens to treat gonorrhea. So the preferred regimen is ceftriaxone. And then if someone has a cephalosporin allergy, you can consider giving them gentamicin and a 2-gram dose of azithromycin, which sounds horrible. I don't know very many people that would be able to keep that down without throwing it up. So I would, I would prepare a patient for that if you're giving them that treatment. If ceftriaxone is unavailable, then you can use a single dose of 800 milligrams of cefixime, which is an increased dose compared to the last guidelines. And I should have highlighted, so this is if you're treating an infection that's in the cervix, urethra, or rectum. So these alternative regimens, you can see below if someone has a infection in their throat, these alternative regimens should not be used. You should really consult with an infectious disease provider if someone has a cephalosporin allergy and they have a pharyngeal infection of gonorrhea. And if chlamydia cannot be ruled out, you also want to treat with 7 days of doxycycline, and that's to treat chlamydia. So that's not part of the gonorrhea treatment. Because of these rising resistance against azithromycin, you would no longer want to treat with azithromycin. All right, so let's look at chlamydia. So NATs are also the preferred screening method for chlamydia. If someone has potential risk of exposure in their rectum, you would want to make sure that you screen that area. Pharyngeal screening, we would not normally do pharyngeal screening for chlamydia, but the NAT tests that we use actually include both gonorrhea and chlamydia. So sometimes we'll find a positive chlamydia test in the throat, and if there is one, we should just go ahead and treat it, not necessarily because of harm to the person, the individual patient that has the infection, but the chance that they might spread it to someone else. Doxycycline is now the preferred treatment for chlamydia, and this really has to do with this issue of anatomical sites. So there is some concern that azithromycin may not work as well for rectal infections, but doxycycline does have better efficacy. In folks who have a vagina, they will often have a rectal infection as well, regardless of whether they've had anal sex or any sort of exposure to chlamydia in their rectal area. And this just really has to do with the proximity of the vagina and the rectum. So we want to make sure that even if we're not screening the rectum because someone doesn't have risk at that location, we want to make sure that we're giving them a drug regimen that actually covers a potential infection in that region. So these are the treatments for chlamydia for all anatomical sites. So for someone who is not pregnant, doxycycline for 7 days. An alternative regimen would be to use the azithromycin, although it's not ideal as we've discussed, and then or using levofloxacin. If someone is pregnant, we generally don't give doxycycline to people who are pregnant because it can build up in the bones and teeth of the baby and cause some discoloration. So you would want to treat with azithromycin in that case. And as an alternative, you could treat with amoxicillin. So Trichomonas. So Trichomonas is still the most prevalent non-viral STI worldwide. And there's multi-dose metronidazole is now recommended for treating Trichomonas in women. So, and this is based on new evidence, including a large multi-center trial of HIV negative women that showed that if you give multiple doses of metronidazole to women, you're going to reduce by half the number of women who will have a positive retest in 1 month. So this is giving them multiple days of metronidazole as opposed to a single dose. There's no treatment changes for men, so men can still receive that single dose. And the guidelines now acknowledge that metronidazole, or the alternative agent, tinidazole, do not inhibit acetylaldehyde dehydrogenase like disulfiram. So any sort of disulfiram-like reactions that we thought might have been attributed to metronidazole in the past are probably actually related to someone being intoxicated with alcohol or some unrelated side effects. So basically, we used to tell people if you're taking metronidazole, you should not drink alcohol, or if someone came in to the clinic or the emergency department intoxicated, we would not give them metronidazole for fear that it would cause this sort of like violent, like anti-abuse reaction. And we now know that that's not scientifically grounded, and it's perfectly fine to give someone metronidazole if they're intoxicated, or if they if they plan to drink alcohol. So here is the Trichomonas treatment for all anatomical sites. So for female patients, it would be 500 milligrams twice a day for 7 days. Men can still get the single dose of 2 grams. And then there's the tinidazole, which is a word that I have trouble saying, as a single dose that can be given to women as an alternative regimen. The changes or the guidelines do also include a section on sexual assault or abuse. There is one on adults and adolescents, and then also one on children and infants. There's very few general management considerations that have been changed. There are some recommendations as far as STI prophylaxis, which I'll show you here in a second. And then there's also a new recommendation that survivors receive counseling on PrEP if they have ongoing risk for HIV, and also try to make referrals or linkage to PrEP prescribers if someone has ongoing risk and is interested in PrEP. So that's new to the guidelines. These are the post-assault STI prophylaxis changes related to adults and adolescents. So for female survivors, you want to give ceftriaxone, cover gonorrhea. You want to give doxycycline to cover chlamydia, and then the multi-dose metronidazole to cover for trichomonas. For male survivors, don't need to provide the metronidazole, but you would want to do the ceftriaxone and the doxycycline. And this is not related to sexual assaults, but I just wanted to point this out, that if you are seeing a man who has sex with men, you're more likely to find infections in places other than their urethra. And so you need to make sure that you're screening those areas if you want to be effective with screening. So a lot of times what I will see is someone will go, a man who has sex with men will go to say like an urgent care for an STI screening, and they just get their urine tested. So if they have an infection of gonorrhea in their rectum or in their throat, that's going to be completely missed. These are some data from Multnomah County that show that if you were to testing men in different anatomical sites, and kind of the biggest bang for your buck here for both gonorrhea and chlamydia is to check the rectal site. You're more likely to find asymptomatic infections there. And then this is a cute little ice cream cone analogy for doing a STI screening in a man who has sex with men. So you want to make sure that you screen rectum, urine, pharynx, do a hepatitis C screening depending upon their risk, and then make sure that you get a syphilis screening. And this could potentially not just be MSM. If someone who's not MSM is also having anal sex, they need to have their rectum tested or their pharynx tested and so on. It can be kind of confusing for patients to find PrEP and get it paid for and figure out how they're going to manage all of this. It can also be confusing for providers. So I wanted to make sure there's some resources here. So if you're in the Portland metro area, any of these counties that are listed here below, Cascade AIDS Project has PrEP navigators to help people navigate PrEP. And then the rest of the state is covered by HIV Alliance. So these are helpful referrals to have here. Here's some other resources. So if you want to look at the guidelines, there's a link there. I also encourage you to utilize the PrEP line and the NPEP or PEP line at University of California, San Francisco. You can call, leave a message with questions, and they'll have an expert will call you back and provide some consultation. There's also some links here to the medication assistance programs for the regimens that we use for PrEP. And that's it. I very much appreciate your time and your attention. I think STIs and HIV now more than ever require our attention and vigilance, both in screening and identifying new cases, and also in effectively managing these cases and treating them so that we can decrease morbidity related to sexually transmitted disease. So thank you very much.
Thank you, Chris, for providing that presentation, and thank you everyone for being here. We're now going to turn it over to Chris to answer any questions that you all have. Feel free to put them in chat or raise your hand. Aislinn and Carly will be monitoring that. And we also have Ashley Allison here from the Oregon AIDS Education and Training Center. So anything you want to ask both them, this is a great opportunity.
I know when we talked previously, we talked about how there were slight differences in the syphilis screening recommendations. Do you want to speak on that briefly?
Sure. So I think in the slides, I incorrectly say that there's not really any changes to syphilis screening. There is one in relation to syphilis screening in pregnancy because of the rise in congenital syphilis cases. Previously, it was recommended that there would be a test at sometime between weeks 28 to 32. And now the recommendation is just to do it at 28 weeks so that we can identify those congenital cases or potential syphilis infections in the mom right away, so we can treat it and prevent congenital cases. So it's kind of a finer point, but I wanted to make sure that I highlighted it.
I appreciate that. Thank you. I actually have a question that I'll jump in with while folks are thinking of theirs too. I was really surprised about flagyl and alcohol no longer being like a strong contraindication, because that was something that's been drilled into me for the past, 6 years since I got started. And it certainly opens up a lot of opportunities for us as SANEs in the hospital environment. If that's not an issue. I was wondering, do you know how was that change finally discovered? Like, do you know more about the background of like why that was such a big thing for us for a while, and how they realized that it's not actually something we need to worry about?
Yeah, that's a really good question, and I don't have the answer to it. I was actually talking to one of my physician colleagues recently about it, and she, I think she graduated from medical school maybe in like 2014, something like that. So she was trained slightly later than I was. And she said that in their training, they were actually told about this, this sort of myth around flagyl causing an anti-abuse reaction. So that knowledge has been present for a while. I don't know why it is. I don't know if there's like a specific study that came out recently that sort of finally debunked it, or whether the guidelines are just kind of catching up with current evidence. But we don't have to worry about giving flagyl if someone's intoxicated or or might be drinking, which kind of goes against every grain in my body, because that's usually part of the education that I'm providing to a patient when I'm prescribing that medication, but it's not.
Yeah, me too. I
not a
can like
problem.
feel the like anxiety around it, but also like really
Mhm.
glad to know about that change. So
Mhm.
I'll definitely be sending out that information far and wide so that we can get that changed around the state. Thank you.
Mhm. And the other thing is, I don't know where that myth ever came from, which would be kind of interesting to know as well.
Mhm. That
But
kind of thing always makes me wonder, like, what else am I taking for granted that,
mhm.
I haven't gone back to like primary sources for.
Mhm.
That's good to know.
Mhm. It's hard. It's hard to change practice. It's a slow process.
It is. I imagine that even, blasting that information out, it's going to take a little while for that to really permeate different areas of the state. So
Mhm.
the earlier we start.
Yes. Any other questions?
I will just mention quickly that it's I think Chris was one of the first people to put together an STI update so quickly after the guidelines came out. Excited about like the day they hit. I was like, Chris, can we do this? And he's like, yes, I'm putting it together now. So it's so exciting to be able to deliver this information to all of you so quickly. So I want to just say thank you to Chris for that. And there's a couple of resources listed throughout that slide deck, and I will just say is the AETC, we're really well connected to like PrEP navigation services in the state. And so if you have any questions about that or any follow-up questions you have about resources or linking patients to resources, please feel free to reach out to me or visit our website, and I'll put that information in.
Thanks, Ashley. And then I'll also make sure to put that information in the session description so that folks have that there as well. Easy to click on.
Perfect. Yeah, and I think Nicole, I sent you there's a PrEP provider list, a statewide PrEP provider list. If
Yes.
you're trying to find a PrEP provider in the area that a patient lives, that resource is really helpful. We try to keep it as up to date as possible. And I'll put that in chat, but I think, yeah, Nicole's also linking it as a resource.
And I really appreciate you for providing this forum for HIV and STI prevention at the summit. I think these are important topics, and I appreciate everyone's interest in them.
Thank you.
Oh
no, go ahead.
I was just going to say, if folks don't have, like, if questions arise later, I'm also always happy to address questions after the summit as well.
That sounds great. And Chris's email is also in the Whova app. So folks are welcome to reach out through that, or if you end up having trouble finding it for any reason, feel free to reach out to me, Nicole Broder, and I can get you connected as well. I think you just did such a complete and thorough job in your presentation that we don't have lots of questions, which is great. I know I learned a lot, which is always great. It's kind of the plus of getting to organize these things, as I get to find out all the stuff that I've been wondering about.
Yeah.
So thank you again for providing that.
No problem. Super happy to present at the forum or at the summit.
And Beth mentioned, even for those of us who are advocates, non-medical providers, it's great information. I agree, Beth. I think just like having that knowledge out there is so useful. Okay, well, we'll leave it going for just like a couple more minutes. But Aislinn is going to go ahead and put a link to an evaluation in the chat. It's also available in the session description on Whova. And if you guys don't mind just taking a couple of minutes to fill out that form, let us know what you thought about the presentation and everything. And if you are a nurse, you can also request continuing education credit through that form. So it's there in chat. We'll leave this up in case anyone has any last minute questions. But besides that, thank you guys so much. Thank you, Chris. Thank you, Ashley. And thank you for everyone who showed up today. I hope you have a great rest of your afternoon.
Thank you so much.
Thank you.